Kwong?
Okay, I don't really have any other announcements, so we're going to just go ahead with the content for today. So as Andy said, this is the second webinar of our 6-part telehealth webinar series. And this one is telehealth policy. So joining us today is Kwong from the Center for Connected Health Policy, or CCHP. So May joined CCHP in 2010 as a policy associate and was named executive director in January 2018. She leads the organization's work on public policy issues as they impact telehealth on the state and federal level. She is also the project director for the National Telehealth Policy Resource Center. She is a nationally recognized expert on telehealth policy. In her current role at CCHP, she works with the organization's multitude of national and regional partners on telehealth issues and oversees CCHP's projects, provides policy technical assistance to state and federal lawmakers, industry members, providers, consumers, and others. She has published in peer-reviewed journals and is a sought-after speaker at national conferences. So May, I will let you take it away.
Thank you, Nicole, and thank you everyone for having me here today. As Nicole mentioned, my name is Kwong, the Executive Director of the Center for Connected Health Policy, and I start off every talk with some disclaimers. Because we are federally funded, I really have to start out this way, especially since when people see that JD attached to my name. So just to let you know, any information that I provide today should not be considered legal advice. It is strictly for informational purposes. CCHP always recommends that you consult with legal counsel if you want to form a legal opinion. And also know if I happen to mention a company or show a picture of a product or anything like that, know that neither I nor CCHP has any type of relevant financial interest, arrangement, or relationship or affiliation with such a company. A little bit of background about CCHP. We actually started off as a California telehealth policy organization. We're a program underneath the Public Health Institute, but an opportunity to become the federally designated National Telehealth Policy Research Center became available in 2012 through a grant from HRSA. CCHP applied for that, we got it, and we've been serving in that capacity ever since. We also work with a variety of other funders and partners on the state and federal levels on other projects related to telehealth or connected health. We're also the administrator for the National Consortium of Telehealth Resource Centers, and I'll explain that in a little bit more detail in a second. And we're a convener for a group in California called the California Telehealth Policy Coalition, which is a coalition of over 100 statewide organizations who are interested in advancing telehealth policy in the state of California. I mentioned the National Consortium of Telehealth Resource Centers. So there are 14 telehealth resource centers underneath the same grant program that CCHP is under with HRSA. There are 12 regional resource centers and they cover specific states. And then there are 2 national centers, one on policy, which is CCHP, and one on technology that's based out of Alaska. The 12 regional resource centers, as I said, cover specific state and consider them sort of your frontline telehealth resource folks. So if you have a question about, how should I start a telehealth program, or, what does my state Medicaid program do around telehealth, or, what do I need to consider regarding like licensing if I'm like in Utah, but I want to, service clients in Montana. They're a great resource to reach out to first. And because they're federally funded, the majority, I would say about 99% of their services are free. You start getting into like very complicated issues, extensive amount of time. They may talk to you about a contract, but for the most part, they're, happy to answer your questions regarding telehealth or like equipment or, workflow, anything, practically anything related to telehealth and starting a telehealth program. Where they do run into questions about technology or policy that they can't quite answer, then they elevate it up to the national level. And that's where CCHP and the Technology Resource Center step in to try to help out. CCHP and what we do, we also do take questions from other people, not just the resource center. So we've helped everybody from congressional members and state policymakers to health systems, health plans, provider groups, national associations, and also during what we saw in COVID, directly from consumers and patients alike who were interested in telehealth or trying to get services via telehealth during the pandemic, but simply didn't know where to start. To make our resources go a little bit further, the 14 TRCs decided to form this national consortium of telehealth resource centers. And what that means is we just combine a bit of our resources from our grants into one common pot that we utilize to work on joint projects. So for example, when there were conferences, we would exhibit at conferences jointly underneath the National Consortium umbrella, or if there are resources that, spread across, can be applicable and spread across multiple regions or nationally, such as fact sheets or toolkits on, like, say, remote patient monitoring, we develop those together in order to, cut down on duplication and waste of resources. But, if you reach out to like one of us, because we are in such close contact with each other, you really are getting all 14. So even if you reach out to somebody initially and they're not quite the right person, they will refer you to the right person. So we're going to talk about telehealth policy today, and this can be kind of a complicated subject to get into, especially if you're not quite familiar with telehealth policy. So I'll try to break it down into pieces that are a little bit more manageable. First off, telehealth policy itself. So before the pandemic, a lot of the policy that existed around telehealth that was specifically regarding telehealth had the word telehealth to it, like applied to telehealth, was really around reimbursement. So what was covered, what services are covered, who can get paid if they utilize telehealth. And that telehealth reimbursement policy can be broken down into 4 elements in itself. So there was usually a policy touching upon one of these 4 elements, and that was what service was covered, where the patient was located, the modality that was used to like deliver the service, and the provider who's delivering the service. So for example, you can have a policy, say, a Medicaid program. My state Medicaid program will cover mental and behavioral health services, the service that's covered, when the patient's located in a clinic or hospital setting, the location of the patient, when it's being delivered via live video, the modality that's being used, and when it's being delivered by a psychiatrist or a licensed social worker, the provider who's allowed to deliver that service. And that's where you see a lot of like the policies and how they were structured, both on the federal and the state level when you're talking about telehealth reimbursement policy. Now, there are other policies that do touch upon telehealth that may or may not have some sort of specific telehealth component to it. For example, a lot of states have laws regarding how you can establish a patient-provider relationship if telehealth is used, or you have what's on the federal level, prescribing controlled substances. There's like a section there devoted to like how you can use telehealth to provide those controlled substances. But for the most part, the existing telehealth policy before the pandemic was really around like reimbursement and like what's covered, who gets paid, when can they get paid, etc. So we're going to take a look at what the pre-COVID landscape looked like, and you'll see like why there were so many differences when we hit the pandemic, why so many changes had to be made, and why it was actually pretty incredible that they made so many rapid changes so quickly. And also probably why it was confusing to a lot of people because there were so many changes made so rapidly. We'll take Medicare policy first. So on the federal level, when you're talking about telehealth policy and you're talking about reimbursement, it's Medicare. Yes, the VA does telehealth as well. Yes, there's like prescribing laws related to telehealth, but really the bulk of the existing policy is about Medicare. And that's where you saw a lot of the COVID changes. Now, Medicare, you have to understand, has 2 approaches to the provision of care when you utilize telehealth technologies. So there's the Medicare policy that's related specifically to telehealth. And that is policy that says the word telehealth to it, has telehealth attached to it. And a lot of that policy is embedded in federal law. So CMS itself really does not have like a lot of leeway to like change things because it's embedded in federal statute. And this is where when you hear about people talking about Medicare telehealth policy, where they say, oh, there's like a lot of limitations. That's where it is. It's in federal law. CMS really can't do a whole lot about it until Congress takes action. So in federal law, you have limitations on where telehealth can be, what telehealth can get reimbursed when you're talking about the Medicare program. They limit it by those 4 elements. They limit it by location of the patient. So there's like geographical limitations, there's site limitations, like a specific list of eligible sites. They call them originating sites. That's where the patient's located when the telehealth services take place. But there's also a geographical limitation. It needs to be in a rural area or a non-metropolitan statistical area. And the way they define what rural and metropolitan statistical area is very narrow. I mentioned I'm based in California. So underneath this pre-COVID sort of policy that you had for telehealth for Medicare, about 98% of the state of California will be ineligible to be an eligible originating site underneath those policies for Medicare. So telehealth could not take place for a Medicare patient where the provider would get reimbursed for it. There's also limitations on the modality that's being used. It's basically live video that's allowed. There's also limitations on the type of providers. There's a specific list of providers who are allowed to do it. And then there's like a limitation on the eligible services. Now, the eligible services portion, that is actually not embedded in federal statute. That is actually the one element where CMS does have leeway to decide their policy without waiting for Congress to tell them, like, you know, what they can do. So that is the one area where CMS has a lot of control. But for all those other three factors, it's pretty limiting. So if you like don't meet all three of those factors, your patient's not going to be able to utilize telehealth, and the provider isn't going to be able to get paid for delivering that service via telehealth. Now, that's a telehealth policy in Medicare. Medicare also has this other sort of bucket or channel of telehealth delivered services that they don't call telehealth. They call them communications technology-based services. Now, they utilize telehealth technologies to deliver the services. They utilize live video. They utilize the asynchronous version of store and forward. They utilize remote patient monitoring, but they don't call these services telehealth. Now, why don't they? Well, originally, way back when they started doing this back around 2015 or so, it was basically, I think, a way for CMS to work around the statutory restriction, because they realized that there were these technologies that could help patients and probably cut down on costs too, but nothing was moving through Congress. But what their sort of official reasoning is that when you're talking about telehealth and services that are delivered via telehealth, that's a one-to-one replacement for something that would take place in person. So that is what it is. Telehealth replaces an in-person service. Communications technology-based services, these are services that the technology these days allow us to provide that you simply wouldn't do if you did it in person. So for an example, a one-to-one replacement for an in-person service, I go and visit my primary care provider. I can do that via telehealth, that office visit. So that's a one-to-one replacement. Communications technology-based services, let's say I'm a patient with hypertension and I'm taking readings multiple times throughout the day for like a period of time, and those readings are being sent to my healthcare provider. Well, I typically would not do that in person. I wouldn't be going into like a clinician's office like a couple times a day over a period of like, consecutive days in order to get that blood pressure reading. But it's something now that the technology allows us to do. So CMS has said, it's not a replacement for an in-person service. It's this other thing that technology allows. So it doesn't fall underneath telehealth. That was meant to replace in-person services. So it's this other thing, still to utilize this telehealth technologies, but it's this other thing, which means it doesn't come underneath all those statutory restrictions that telehealth has. So we can create our own policies regarding this, and we can do our own thing about this, and we don't have to wait for Congress. I'm spending a lot of time on this because I want to make that distinction very clear. It got very muddled in those first couple of months of COVID because CMS was doing policies around telehealth and relaxing policies, but they were also saying, but keep in mind, these communications technology-based services are here too. And I think for a lot of providers who are new to telehealth, and the telehealth policies got the two mixed up, especially when you were talking about audio only, where they allowed you to use audio only phone to like provide services. That was always an option for some of the services underneath communications technology-based services. But then they allowed that underneath their telehealth umbrella as well. So people were getting very confused about the two things. And then they were wondering, you said CMS and Medicare allows us to use audio only phone, but I only got paid $10 or $14. And then I would ask them what code they billed. And I would say, oh, you billed a communications technology-based service code. You did not bill a telehealth code. That's why you got paid less. So there was that bit of confusion there as well. So I just want to make it very clear. With Medicare, it's these two separate channels. Now, when you start talking about the states, that gets a little bit murkier. So we'll just like go and see what the states do with telehealth. So the states actually were a lot of them were actually more advanced than what Medicare have been doing. They've been making changes over the last couple of years, like expanding their telehealth policies. I've been doing this for about 10 years at CCHP, and I've seen the changes. So yes, states have been like more progressive than the federal government around in Medicare and CMS. So before the pandemic, you had about 50 states, all the states in the District of Columbia, doing something in their Medicaid program, reimbursing for something via live video. Store forward remote patient monitoring, not as popular. And that's actually significant going into the pandemic, because if you're talking about a Medicaid program that allows services to take place in the home, most likely most of them were around remote patient monitoring. So that meant a lot of states had to make adjustments to their policy during the pandemic to allow the home to be an eligible originating site. But this was kind of the landscape before the pandemic. States also have commercial payer laws. So this is what, private payers, health plans are told to do around telehealth. Now, these laws vary. They range from everywhere from a state saying, health plan, you can cover telehealth if you want to, but we're not going to require it, all the way to a state saying, well, health plan, you will cover those telehealth delivered services the same way you would have in person. And by the way, you will pay them the same amount you would have had they done it in person. And then everybody else kind of falls in between. So when the pandemic hit, this kind of dictated how much control a state may have had in like directing commercial plans operating within their jurisdiction to say like, this is what you're going to do about telehealth during the pandemic. To be fair, a lot of health plans made that decision on their own. They really didn't need the state to like order them, but the commercial payer laws that some states had on the books gave them that authority to be a little bit more, to put more mandates on health plans during the pandemic. Now, I said that the communications technology-based services codes that question gets a little bit murkier on the state level as far as like how the states approach it. If you notice, I'll go back. On this slide, I said states were already reimbursing for remote patient monitoring store and forward. For CMS and Medicare, that falls into their communications technology-based bucket. But before that, those codes, that whole idea of communications technology-based services existed. States were already doing some of this. So you have this kind of like, well, states were already doing things that CMS and Medicare consider communications technology-based services. They were already reimbursing for that type of stuff. So what do they do for all those communications technology-based service codes? And the answer is it varies. And they kind of treat it almost as it's just a separate code. So they don't necessarily say, a state doesn't necessarily have like, oh, this is our telehealth policy. And yes, there's like some store and forward remote patient monitoring stuff in there. And then we also have another policy around communications technology-based services. A lot of states don't separate it out that way. What they do is they look at what CMS has done for some of those codes for the communications technology-based service codes, and they just put it into their fee schedule. They just say like, we're just going to reimburse this code and this is the amount that we're going to reimburse it, and they don't identify it. So you have to go into their fee schedule and kind of dig around, see like, and search for that code, see like, are they doing something with that? So it's very mixed up as far as like how the states approach it and what they do for it too. So prior to the pandemic, CCHP actually did go into all the fee schedules and look to see what they were doing. And it's a mixed bag. That report's actually kind of out of date now because we did that before the pandemic. So it was like the 2020 numbers. We haven't had an opportunity to look at, the updates for it, but it was sort of a mixed bag of what folks were doing, what states were doing. Some of them were reimbursing for some codes. Some states were just like, we're not touching that. And then the pandemic hits. And then that starts becoming like, well, maybe they start adopting some of those policies or start combining those communications technology-based service codes in with their telehealth policies as well. So COVID-19, probably the most obvious slide in the world. It changed everything. So definitely changed everything for telehealth as well. And this is sort of your like 100,000-foot level overview of like what were all those changes both on the federal and the state level. And these are kind of like the issue areas in which, the policy changes that were made on the state and federal level touched upon. As you can see, a lot of them relate to like those 4 elements of telehealth reimbursement: location, the modality, the type of provider who's eligible, the type of services that's eligible. Again, also other things were touched upon, such as like prescribing, especially in controlled substances, HIPAA, privacy and security. Again, nothing really related on the federal and the state level for the most part regarding privacy and security and telehealth. Usually the policy was just like for telehealth was, You agree to abide by the HIPAA standards and like the privacy and security if you're delivering services via telehealth. So not a lot of specificity on those privacy and security policies related to telehealth, but obviously an issue when you're trying to like do what you were trying to do at the beginning of the pandemic, which was to stand up programs very quickly. So this is like kind of just an overview of what you see of like what was touched upon. So what were the federal policies? Again, this is just a repeat of that slide. So what was happening on the federal level was basically around Medicare for the most part. And a lot of the changes that had to be made were around those 4 elements. So CMS made changes to all four elements. They added like an additional 140 service codes that were eligible to be delivered via telehealth, at least temporarily during the pandemic. They also after Congress in the CARES Act allowed this, they removed the geographic and the site limitations. So it can now take place in urban and rural areas, but the home was also an eligible originating site. They allowed audio only phone. So they didn't talk about the store and forward and remote patient monitoring, but they talked about audio only phone. And this is significant. So before the pandemic, for the most part, most people, when you talked about telehealth and defined it and talked about modalities, audio only did not appear on that list. In fact, a lot of state jurisdictions explicitly excluded it in their definitions for telehealth and telemedicine. They would say, this is what telehealth and telemedicine means. And by the way, this does not include like telephone, email, and fax. So they would explicitly exclude that. However, policymakers quickly realized not everybody's going to have access to telehealth. They may not have broadband. They may not have the right equipment. They may not have the digital literacy to get connected. So how are we going to reach them? We got to allow audio only phone for at least some of the things. And that's what CMS did. They allow audio only, but for a certain band of services. They didn't allow it like wholeheartedly for everything, just for certain band of services. And then also the congressional changes allow them to temporarily open up the provider list. Significantly before the pandemic, federally qualified health centers and rural health centers were not on that list of eligible providers to provide services via telehealth. Problematic when everybody's sheltering in place and they need primary care services. They were probably getting them from an FQHC and RHC. So that needed to at least be temporarily changed. They also opened it up to like other healthcare professionals who were not on that eligible list, like allied health professionals, like OTs and PTs. So basically CMS just said when they got the go-ahead from Congress saying that we'll open up to any eligible Medicare provider as long as they're providing one of the services on like the eligible services list. They also made changes to HIPAA. Basically, what they said was the Office of Civil Rights will exercise judgment and discretion in not pursuing, basically dinging you for not abiding by HIPAA. Now, when that happened, I was still telling people, I'm like, just pretend HIPAA is still there. I know you're trying to like do this, but just pretend HIPAA is still there. It'll save you a lot of headaches down the road. And by the way, they said they would exercise discretion. They did not give you like assurances they were not going to prosecute. So just pretend like, HIPAA was still there. It's totally fine. You can do it quickly and everything. There's like a lot of platforms out there that you can utilize that are HIPAA compliant and everything. So, but so that was also something that was relaxed. And then there was the Ryan-Haight Act, which was prescribing a controlled substance. That's the shorthand a lot of telehealth people use. They call it the Ryan-Haight Act, because in the Ryan-Haight Act, there's like a section in there for telehealth saying like, these are the situations where you can use telehealth to prescribe a controlled substance where that telehealth prescriber has not seen the patient in person. And the exceptions were very limited. They were very narrow, such as the patient was in a DEA licensed facility when he was or she was interacting with the telehealth provider, or the patient was with a DEA registered provider when the telehealth interaction took place. One of the exceptions is when a public health emergency is declared. Public health emergency was declared, the exception kicked in, so that meant you can prescribe controlled substances via telehealth, and you didn't have to meet one of the other exceptions like being in a DEA registered clinic or with a DEA registered provider. Now the question is like, what's going to be made permanent, because we have all these changes that have taken place. Here's just like sort of like a little bit more detailed as far as like the 4 elements. Now, I do want to say this is just sort of a slice of like the changes that were made on the federal level. There were a lot more that were necessarily related to reimbursement. For example, CMS made changes around frequency limitations. So skilled nursing facilities before the pandemic, they were limited to one telehealth visit every 30 days underneath the Medicare program. COVID-19 hits, they do away with that frequency limitation. There is also sort of supervisory limitations, like over residents, saying that they needed to be supervised in person. They allowed them to do that via telehealth. So there were all these other policies that CMS made temporary adjustments to in order to, like, you know, again, minimize the contact that people have, allow, like, you know, people still receive services, but, you know, try to do it in a more safe manner, especially when we had, like, you know, this infectious disease like going on, raging outside. So the question is, what's been made permanent so far? There's two channels to do that. You can do it the administrative route, and that's CMS saying like, we're going to make this permanent, or the legislative route, which is like congressional action and the president signing it. I talked about like how CMS is actually pretty limited in what they can do administratively. So they focused in on that, like what the changes they can make there. And then, you know, we have to see what legislatively Congress is doing. So the way CMS decided to go about this is through their physician fee schedule. For those who are not aware, so the physician fee schedule, every year CMS comes out with their proposals for changes that they want to make to the Medicare program administratively for the following year. So the changes that took place or went into effect for 2021, they made those proposed changes in August of 2020. They were a little late last year. It's usually out in July. And then they go through, like, you know, this public opinion process, public comment process, and then they finalize it towards the end of the year. Like it was in December, I believe they finalized it. And what they did was what they could do, which is really around those services. That's like the only control CMS really has around telehealth policy, where they don't have to wait for Congress. So what they did was, we are going to put on the permanent telehealth list these codes that are on that temporary telehealth list right now that we have for COVID-19. I said there were 140 codes that they had on that list. This is about 9. So about 9 of them they're saying we'll make permanent. And the reason they said like it's only these 9 is because CMS way back when had set up basically how you like get codes approved to be on the permanent telehealth list. And they call them like a category test 1 or a category 2 test 2 way. So this is to get on the permanent telehealth code list for Medicare. You either have to pass the category 1 test or the category 2 test. Now, the category 1 test is a code can get on the permanent list if it's very similar to a code that's already on the permanent list. And that's usually the way that codes get on, because that's kind of the most clear-cut test there is. Because the category 2 test is, well, if you can suggest a code, and if you can provide us with enough evidence that it's as good as in person and can be safely and effectively provided via telehealth, then it passes category 2. Problem with the category 2 test is like, it's very vague. CMS has never like really given like the parameters around like, well, what's a passing grade then? I mean, is it like you're published in like 5 peer-reviewed journals? Or like your study, you have a study that involved like 200 subjects? It's never been clear. They just said like, if you pass the test, you'll get on the list. So basically, for the most part, at least as long as I've been doing this, everything just passes on category 1 test. So these are the category 1 things that CMS at least has said, they passed the category 1 test. We're proposing them for the permanent list. 9 out of 140, not a whole lot, but that's what they proposed. But then they came up with this other idea, and they said, you know, there's a bunch of other codes on this temporary COVID list that we think might be okay. We're just not quite sure yet. We don't have enough evidence. We don't have enough data. So we're going to create a category 3 test. So the category 3 test is a temporary bucket. And we're going to, all these codes that fall into category 3, we're saying that in the year the public health emergency is declared over, these codes in category 3, they're going to stick around until the end of the year. That'll give us more time to examine them, get more data to see if they can pass a category 1 or a category 2 test. So for example, let's say the public health emergency ends June of 2021. All the policies that haven't made permanent, they revert back. All those codes that aren't on the permanent telehealth list, they go away. You can't provide them via telehealth anymore, except the category 3 ones. They get to stick around because they're category 3. They stick around until the end of the year because CMS has said that that'll give us enough time to assess whether they can pass a category 1 or category 2 test. As you can see, a lot more. There's like maybe around 30 to 40 additional codes here. What's interesting though is like they added therapy, physical and occupational therapy codes on here. But the problem is even if these codes get on that list, OTs and PTs are not eligible providers until Congress changes that list. So I've been asked like, well, why did they do that? And I said, well, they went through this whole convoluted thing and that like maybe a physician can bill incident 2. They follow all the incident 2 rules and everything, but you know, they think that's still narrow. My guess is that some of these codes, which like we're like, wait, they're not going to be possible if all the policies stay the same, like the OTs and PT things, is that maybe they're anticipating Congress making some changes as well to like some of the other policies, and they're just getting it ready. So anyway, this is your category 3 bucket. Public health emergency ends. These things stick around at least until the end of the year that public health emergency ended. There were, now getting to our communications technology-based services, they made some adjustments, some clarifications in there. They expanded who the providers could utilize some of the codes or some of the services, provide some of the services. Now keep in mind, since this is not telehealth, this is something CMS totally created on their own, they can write whatever policy they want. So they like were able to craft this, didn't have to wait for Congress. And they said like, yeah, we can go ahead and let PTs and OTs provide these services and bill for them as well. And they also made other clarifications as well, as far as like some of their other areas, such as like the, you know, RPM services that they offered as well. So I mentioned a couple of other policies that CMS did temporary waivers on that aren't related directly to reimbursement, but how you can use telehealth. So some of those they made changes to. I gave the example of the skilled nursing facility. Remember, I said pre-COVID-19, it was one telehealth visit every 30 days. They shortened that window. They said we're changing our policy. It's going to be one telehealth visit every 14 days in a skilled nursing facility. And then they made other, you know, adjustments as too. But they're not the big adjustments. They're not the like, you know, expanded list of providers. They're not like the removing of the geographic and site limitations. So what happened on that end? What's going on with that? Well, as I said, that requires Congress to take action to make changes to. And there have been 2 significant congressional actions basically since like towards the end of the year and this year as well. And the first one is the Consolidated Appropriations Act, which passed in December of 2020. It was right around the Christmas holidays, so probably a lot of people like were aware of it, but maybe didn't dive deeply into it. There were 2 specific telehealth policy changes that were made there. Neither one related to any of the waivers that we've seen during COVID. One of them was to expand the eligible originating sites. They added critical access hospitals or other rural health facilities with less than 50 beds. They called them rural emergency hospitals, is like the label that they gave them. They can now be eligible originating sites. My understanding is this does not kick in until 2023 though. So that's passed, but it's not quite active yet. And it's also, while we're underneath the public health emergency, it really doesn't matter either because basically anything can be an eligible originating site. And then the other thing that they allowed was that they said mental health services can be used, like all of the services can be delivered via telehealth. Sounds great. They added a caveat though. They said, you know, yeah, you can do it in the geographic limitation and doesn't, you know, isn't applied and it can take place in the home. But they said there needs to be one in-person visit with that telehealth provider at least 6 months prior to those telehealth services taking place. So that really kind of narrows the window down, the effectiveness, the reach of it, because part of the reason telehealth was being used was that, you know, the provider might be a good distance from like the patient as well. But now you're going to have to require this in-person visit, this one in-person visit beforehand. That kind of like defeats the purpose in some ways too. So that was a bit of a surprise to seeing that, but those were the only telehealth specific changes that we saw in this congressional bill. There was some funding for broadband as well, which was great also, but that was basically it in the Consolidated Appropriations Act. Then we have the Reconciliation Act, which took place earlier this year. Again, not really any telehealth policy changes. There was just basically funding for some programs, which is all good and great and everything, but you're not seeing telehealth policy changes. What does that all mean? Well, let's take a look at what some of the other federal actions have occurred. So we heard the Biden administration basically said that, you know, we're extending public health emergency towards the end of the year, and they just did renew it. Secretary Becerra just did renew it on April 15th, so it's good for another, what is that, 60 or 90 days. It sounds like they'll keep doing that at least until the end of the year. I think what we're going to see from the Biden administration is likely, you know, more calls for data on telehealth before they commit to making a policy change, and looking at you know, really what should we keep around. And I think that's going to be being mirrored also in what some of the congressional players are saying as well. I've got a whole list of bills here that I'm not going to go over that, you know, some of them include making the temporary changes permanent and other things that aren't necessarily related to temporary changes that they touch upon, such as the TREAT Act, which is around licensure. And that would be basically allowing temporary licensure across state lines during the public health emergency. The reason why I'm not spending a whole lot of time on these is because I actually don't think any of these bills have a chance. I think what's probably going to happen is, if anything's going to happen, they'll take parts of some of these bills and put them into a larger bill, like Consolidated Appropriation Act, like a CARES Act, if they're going to do anything. But there's a couple other things that happen on the federal level that kind of gave me pause in what might be sort of the future, what we'll see down the line. Other federal developments. On March 2nd, there was an House Energy and Commerce hearing on telehealth. There's going to be another hearing this Wednesday also regarding some of the telehealth provisions as well. What I heard in that hearing, it was 4.5 hours, and I was there for most of it. What I heard was there's a lot of questions around fraud, which was interesting because just a day or so before, the Office of Inspector General came out and said, I know you've seen a lot of news reports about telehealth and fraud. We actually haven't found any. It's been around telemarketing. Yes, there was a telehealth element in the scheme, but they weren't actually billing for the telehealth stuff. They were billing for durable medical equipment. So not quite telehealth fraud, it was telemarketing fraud. We're still investigating though. We're looking for stuff. We're looking at the COVID stuff, but technically we haven't found any telehealth fraud. So it's kind of interesting that in this hearing, you heard about oh, we're concerned about fraud, when OIG was saying well, we technically haven't really found any so far. But they're we're still looking at all the COVID stuff, so who knows. And then there was concern about audio only, which is something that's also replicated on the state level as well. It's you know, we understand the need to keep it around because folks will go without if we don't. And there's going to be disparities, not only with rural populations, urban populations, but maybe with certain population groups, ethnic groups as well, seniors. So we're worried about that. But, you know, is it really as good as in person and live video? Or, you know, should we keep it around? And a lot of questions around that. And then still some doubts about, well, is telehealth really as good as in person? So these are all kind of the things that were being tossed around in that congressional hearing, which a couple other things make me think, okay, there's a bit of let's take a pause a bit on what we're going to do with telehealth here. So another thing that came out was a MedPAC report. For those who don't know, MedPAC is sort of an advisory committee to Congress on the Medicare program. And they come out with you know, I think 2 reports a year. They had a chapter on telehealth, and they were saying, you know what? And let's just put it this way, MedPAC's always been conservative about telehealth. So for them to say as much as they did was kind of a movement forward for them. So anyway, they said, we understand it's good for some things, and we understand kind of the situation about, you know, not everybody has access. We may still be underneath some limitations of in-person services and access issues. So we're suggesting to Congress, you keep some of the audio only around, some of it, not all of it. And we also say, you know, you allow for an extension of the reimbursement services and the location relaxations. We allow for some of that for a period of time. They didn't say make a permanent change. They said just so you can gather more information and study it a bit more, maybe allow it temporarily for another year or 2 after the public health emergency. Interestingly, they did not say anything about increasing the list of providers, eligible providers. They also made some recommendations of like, and this is how you could like probably guard against some of the fraud that, is out there as well. So again, fraud came up. So what does this all mean? I think it means that at least on the federal level, there may be the slight pause of like, we're not going to make something permanent right now. And let me just preface this by also saying, I don't have any inside knowledge. This is just my guess. So nobody has told me anything. But I'm kind of guessing that there may be sort of like PAC is recommending that they may sort of allow a temporary extension beyond the public health emergency for like a year or two before they have to make like a final decision, just so, as they said, to gather more information. I know I'm going on long and I'm giving a lot of information. We're almost done. State level, what's going on the state level? So CCHP looked at the sampling from like 2020 to see like, what are they made permanent? What are they doing? So from July to August, we found that 31 states had made permanent policy changes. Most of them were administrative, so to their Medicaid program. And unless it was labeled COVID or pandemic, we actually weren't quite sure if they were changes made in response to the pandemic or if it could have been a change that the Medicaid program was planning to do. Anyway, again, if it was labeled COVID or pandemic, that was like an easy thing to know or identify as like it's probably related to the pandemic, but some of the changes weren't. So there was like about 31 permanent changes. A lot of them were around, these were kind of the most common ones, phone policy. So allowing phone to be reimbursed in the Medicaid program, but for narrow set of services, usually around the provision of mental and behavioral health. So while they would allow audio only phone, it wasn't for everything. Also clarifying that the home can be an eligible originating site, and then clarifying policies around FQHCs and RHCs and what they can do in the Medicaid program. Before the pandemic, that actually was kind of a gray area in a lot of states. Not a lot of states have very clear-cut policies regarding FQHCs and RHCs or critical access hospitals as well either. It was like kind of very vague of like, they would say like, oh yes, well, we allow you to use telehealth. It's like, who? Everyone? Or just doctors? It would sometimes be very vague in what they would allow. So they were like starting to clean that up a little bit, a couple of the states. State trends that we're seeing as far as legislation, a lot of mental health bills, a lot of SUD bills. Keep in mind, we had two pandemics going on last year, COVID and opioid. So there was concern of like, how do you treat people with substance use disorder? Removing the telephone exclusion from their definition of telehealth or telemedicine, depending on what term they use in their state. And more bills around private payers and licensure. Licensure was a big issue, came up quite frequently during the pandemic and questions that I got from policymakers, both on the federal and state level. A lot of times it started off with, I got a call from my constituent and they're saying that their daughter who just came back from college can't access her student health provider because of licensing laws. Is that true? I say, well, yes, it is. So yeah, I mean, that's the way it is. So there were like, a lot of calls about that, and a lot of them around college students and like coming home and not being able to access their student health providers anymore. And then also bills related to like telling boards, licensing boards and regulatory boards, like you might want to get some telehealth policies there, because a lot of boards had very vague policies, or they didn't have any policies related to telehealth when they were talking to their licensees. So what's next on the federal level? Like I said, I think probably there's going to be a temporary extension once the public health emergency is over. Fraud continues to be a great concern, even though OIG said like we didn't really find anything yet, but we haven't really found anything yet. There's always calls for more data. Just hear that all the time. It's like, give us the data on this. And like I go back with, what data do you want specifically, so people know how to gather that to give it to you. So there's that. Audio only phone. Policymakers, both on the federal and state level, struggle with this. They just aren't quite sure what to keep around. They know it's important to keep around because they don't want to cut people off completely, but they're struggling with it. They're like, is it really as good? Just an audio only interaction. And like, should we pay the same amount? What should we do around this? And then expansion of eligible providers. I thought at the beginning of the pandemic, this would probably be a bit of a slam dunk and we would have more provider list expanded, but it's not really talked about a whole lot, to be quite honest. There's been that focused on audio only phone, except around FQHCs and RHCs. And I think that's probably due to the National Association being very vocal about that. But yeah, but I keep thinking of like all those allied health professionals. I just did a presentation with the with NIH on telerehabilitation. And, you know, they try to like, they're definitely working, their folks are definitely working on that, but I'm just not hearing a lot more conversation around expanding that provider list and keeping that expanded list around. States, again, they're struggling with what to make permanent. They may or may not follow the Fed's leads on like making temporary expansions. I think there might be some states have already made changes. So, you know, they're set, and some have made changes here to like some of their policies, but not all of them. And then others are still kind of like sitting back and waiting to see like what to make permanent. So there may be some sort of like mirroring of what they do on the federal level, which if they go with the, we'll do this temporarily, you may see also mirrored on the state level as well. Also, some states may not be looking at expanding their policies. California, before the pandemic, had actually one of the most liberal Medicaid telehealth policies going into the pandemic. They had just updated that the summer of 2019 when the pandemic hit. And it was very progressive. They came out with proposals to what to make permanent after the pandemic. And I didn't expect all of the telehealth waivers to stick around, but what I did not expect was them to roll back some of the existing pre-COVID policies. And that was what they were suggesting as well. They were actually taking more of a tack of like what Medicare's approach was, where it was like a telehealth channel and almost like a communications technology-based channel, and not quite calling it that, but doing something very similar on how those two are set up. So you may also see some states pulling back a little bit too. So that's about it. I did not have a chance to update the slides. So those links that I have on here, some of the resources, just go to our main website, cchpca.org. Those links no longer apply. We just overhauled our website last week. So like the policies with like all the COVID stuff is now intertwined with like our 50 state report and everything. So it's much easier to navigate. So you just go to cchpca.org and that's like easier for you. And that's it. I'm happy to take questions. Oh, and you guys all can have a copy of the PowerPoint. There's an appendix there. This goes into more details on what happened on the federal level with the changes. There's like a lot more detail there. Just wanted to make sure you guys had that. I'll stop there.
All right, thank you, May. Anybody have a question for May before we start having kind of a conversation with some reactions from Neal Neuberger of Health Tech Solutions and Brock Slabach of the National Rural Health Association?
Yeah, I have a question. This is Steve Barnett in Michigan. We've seen the introduction of some telemedicine into a package of healthcare reform bills at the state level. And interestingly, that particular bill related to telemedicine just squeaked by the House to get over the Senate. So I think it's going to run into a roadblock over there. The question that we're looking for, or the things that we're looking to see defined, is patient-provider relationship and coordinated care. Do you have definitions that could be resourced that I can provide to our state association as we continue to try and figure out, you know, how wide open do we want to make this for providers outside, particularly primary care outside of the state, to gain access to patients in the state?
Yeah, so there were actually quite a few states on that patient-provider relationship who had actually something on their books prior to COVID-19. Just generally, there was what they would say, like you can establish a patient-provider relationship if it's done over live video. That was kind of like sort of the most common thing I saw. Now, the question of like ensuring if it's the whole out-of-state provider issue, I'm not quite sure a lot of them really touched upon that. It was more sort of the mechanics of like, you know, what modality you use. You can look on our website, as I mentioned, like our 50 state, you can like look there to see, because we do have like provider-patient relationship parceled out in like as one of the things where you can do a search for that and see what other states have done. I would suggest, and I can't remember offhand if they have anything specific on the books, but I do know they're very cautious about that. And that's Wyoming. They're very cautious of like the outside provider, like having a relationship or, you know, coming in and like establishing that relationship with the patient, the outside of the state provider. For the most part, most of them would just say like, as long as you're licensed by the state. Like in Michigan, as long as you're licensed by the state of Michigan, you're in good standing, and then you use like live video, you can form that relationship. But I
there's
do
been
know,
no real, there's been no real defining of coordination of care or coordinated care or patient-provider relationship, particularly as it relates to the primary care role.
I don't think in establishing the provider-patient relationship, but there's sometimes, and this is where you're looking at telehealth policy, it's multi-layer. It's like, okay, this is what in statute, but then you got to look at what they tell you on the licensing board as well. So there may be regulations that the state had where they said specifically that if you're that telehealth provider and you're licensed by the state of Michigan, you will agree to send the information that of that visit to the primary care provider of the patient. So that might be in regulations. That may have been how they capture that. It's in basically another section, not necessarily in how you establish that patient provider relationship, but in how you're being licensed or how you're being reimbursed. That's also sometimes in some of the reimbursement policies as well, you might find with Medicaid. So it's kind of like a hunt. You kind of have to make the jigsaw pieces, the puzzle pieces fit sometimes in order to make sure you get that comprehensive picture and you're doing everything correctly.
Okay, thank you so much for your question, Steve, and for taking the time to address it. I do want to ask Neal and Brock quick before we go, because we don't have a ton of time now, but I think for our state flex programs, it might be good to hear from your guys' perspective about what the concerns and obstacles are for rural hospitals and clinics. What concerns do they have currently regarding expanding their current telehealth capacity?
Go ahead, Brock. Do you want to?
No, Neal, you can jump in first and then I'll
Okay.
clean up. How does that sound?
Well, I thought that was an excellent presentation, and have for 25, 30 years done presentations around the barriers in telehealth. And I've always said, as Meg Kwong referred to, it's money, 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 followed by standards, both clinical and technical standards, infrastructure, build out, and broadband. And so I think it's useful from a federal policy perspective to look to, for example, the Biden $2.3 trillion infrastructure plan that includes $100 billion that to make broadband available ubiquitously throughout the country. That goes to a #1 healthcare priority of this administration. And if I can't say it enough, equity. It is all about, and I think the directives have gone out to the administrators that are already in place, that it is all about equity in healthcare, which goes right to the issue of telehealth and rural, right? Gaining equity to healthcare services. A couple of other things that I would mention, the telehealth working group in the Senate, Senators Schatz, Cardin, Scott, Shaheen, have for the last couple of years been working on what had been known as Telehealth Modernization Act. Now I think they're calling it the Connect for Healthcare Act. And I think they're getting very close to making permanent the removal of the geographic restriction for video-only services in telehealth. And they're going to include in that bill, when they introduce it, as I understand it, as of about a week ago, a one-off where Secretary Becerra would be given the option of he would have the authority to get rid of the originating site restrictions on telehealth through Medicare. They're going to remove permanently the list of restricted providers and make permanent PTs, OTs, social workers, speech language pathologists. It looks like they're going to ensure permanency for FQHCs, critical access hospitals, and rural health clinics, ability to provide Medicare services under telehealth. And they're going to make permanent the HHS emergency waiver authority. So again, the secretary would have the discretion to quickly waive restrictions as far as codes and lists of services and those kinds of things that Kwong was talking about. So, they see it as a money-saving kind of bill of about almost $2 billion over 10 years. I would only caution, and I'll stop here, that in terms of Kwong's reference to fraud, we should be taking this opportunity to quickly determine what works, what doesn't, under what circumstances, in an evidence-based kind of way, given the tremendous ramp up in video, audio only, remote patient monitoring, and other services via telecommunications, so that we don't end up getting hoisted upon our own petard when down the road the IG or the Justice Department does start to find out that there was waste, fraud, and abuse in some aspects of this program. We would do our own industry well to start to, for once in 3 decades, have the depth and breadth and scope of medical literature to show the effectiveness of these kinds of things. And we should be working with AHRQ, you know, and whatever they call the Medicare Commission now anymore, I forget what it's called, and those other research organizations to ensure that telehealth, all the telehealth that's being done is needed and necessary, effective from a quality and a cost-effective perspective. I'll stop.
Thanks, Neal. What about you, Brock? What would you say in response to the concerns and obstacles for rural hospitals and clinics?
Well, Neal's exactly right, and great presentation by May in terms of the content of what she did. I just think the imperative is really what we need to be focused on here, and I think that all of this is indicating a disruption to how it is that we're doing our business in terms of rural clinics, both hospitals and rural health clinics, FQHCs. I was at a presentation back in March, and I heard the 5, 15, and 80 rule, that by 2031, which is just 10 years from now, this will be the distribution of revenues for healthcare providers nationwide. 5% will be inpatient, 15% will be ambulatory, and 80% of revenues being paid to providers will be virtual 10 years from now. Now, I don't know if it's going to be 80%. It could be 70%, 60%, 50%, but it's definitely more than the 10 or 12% that we're billing now. And I guess the point that I'm making is that we've got to figure this out. We've got to figure out all the confusion that May did a beautiful job of representing to us today. All the state level issues, and you didn't really address the commercial insurance payers and the confusion that they're creating now in terms of denials of claims that they thought once were approvable but now aren't. So we're getting into this huge retrospective look on these claims. The only other thing I'll point out, and maybe you have resources for this, May, is looking at the content of a telehealth visit. So in the E&M world, the evaluation and management world, 98212, 213, 214, 215, there's a long exhaustive list of what's required to bill in that particular level of service. And we need some kind of analog for that in the telehealth space that's very clear, so that we can set up compliance programs for the content of the visits, so that we can have retrospective analysis within our clinics over what constitutes a legitimate telehealth visit, what was the essential components, how is the data recorded, where is it recorded, how is it retrievable later. And I'm afraid in most of the workflows of a lot of our clinics, we may not be following up with that kind of level of detail in terms of access to information. If telehealth visits are over here in this room and we have paper records, and then we have our electronic health record over here where our patients in person are being seen, in this other manner. So we've got to gain some consistency in workflow. We've got to make this integrated. And I agree with Neal completely. I mean, we don't want to set up a situation where we've got really wildly varied ways in which everybody's doing this work and no consistency in terms of expectation of outcome. And I'll stop.
Yeah, the spot on, Brock. A thing is that the distinction between video and remote patient monitoring and the connected devices through the Internet of Medical Things, diagnostic and therapeutic and otherwise, by the millions, no, by the billions, and electronic medical records, those lines are becoming that much more blurred since the early days of telehealth in the 90s, when it was very clearly, you know, two-way real-time interactive audio or video versus everything else. And now you're seeing just an amalgam of all sorts of technologies and modalities. Some of them FDA approved, others not. Some of them FDA eligible to be approved, others not under 510K approval processes. The developments that have taken place are going to raise a whole host of new questions, including the security of all of this for healthcare organizations, given the millions of additional attack surfaces that are being exposed through these connected networks, and the already denial of service attacks and ransomware attacks and you name it going on in the field. That has almost gotten sidelined given the, as Kwong said, you know, the urgency of the pandemic and the need to get telehealth out quickly, you know, as a replacement for face-to-face visits and things. But that ain't going away. The fraud's not going away. The security issues are not going away. And they're going to get that much more difficult as, you know, large-scale attacks are just seeing it all over the place. Hospitals being held ransom. I used to keep a running list of large healthcare attacks. It's unbelievable the numbers of records that have been you know, breached by the tens of millions through various healthcare organizations.
Well, thank you, everybody. I wish we had more time to talk about this because obviously it's a really big topic. So Andy popped up the polling questions. So we want to hear from you what you feel like you learned from this webinar today. So take just a minute to answer those as you leave. And thank you, May. Thank you, Neal. Thank you, Brock, all for joining us. Like I said, I wish we had more time because I think there's a lot more to talk about here. But I would say join the National Rural HIT Coalition calls because we do a lot of talking about policy and all of these different issues and aspects of telehealth, which is obviously our big focus with that group right now too. So watch for an email about the next National Rural HIT Coalition meeting. Dorothy, I see your question in the chat and I will follow up with you by email about that. Thanks, everybody.
Thanks, everyone.